Good morning, everyone. In our FRCS Viva series, today we are discussing testicular cancers. Anish, floor is yours.
Thank you so much. Good morning, everyone. So you are in the testicular cancer table, and you have a GP referral, a 2-week wait referral for a 26-year-old gentleman who incidentally found abnormal area in the left testis during the self-examination. Nothing else is given in the referral letter. How would you want to proceed?
So I will see this patient urgently. I will do a focus history physical examination, and I will order some tests. My main concern is testicular cancer. So in the history, I will concentrate on the onset of the scrotal mass, the duration, whether it is painful or painless. I will ask also about any risk factor for testicular cancer, like any history of previous testicular cancer in the patient or family history of testicular cancer. I'll ask about any history of undescended testis or surgery for that previously. I will ask also for any specific disease which increase the risk of testicular cancer, like HIV, or testicular dysgenesis, like in patient with a Klinefelter syndrome or 45XO karyotype. After that, I will ask about the patient sexual function and whether he is having any children, whether he completed his family or not. I'll complete the history by asking about the other medical comorbidities, if there's any comorbidities, and the use of any medication, including anticoagulant. I will ask about any history of previous surgery or radiotherapy. I'll ask about the social history, especially smoking, and then I will do a focus examination in the presence of chaperone with the patient consent. I will consult in the general examination for any signs of advanced malignancy or cachexia. I will palpate the supraclavicular lymph node to see if they are palpable. I will examine the chest and look for any gynecomastia. I will examine the abdomen, looking for any palpable masses. After that, I will examine the groin and the genitalia. I will start the examination by the normal testis first, and then I will examine the other testis, the affected one, looking for the mass to see the appearance of the mass, the size, whether there's any tenderness or not, whether it is involving the epididymis, and I will palpate the cord as well. I will complete the examination also by looking for any lower limb edema and do a neurological examination if it is suggested by the history.
All right. So what's the risk of testicular cancer in cryptorchidism?
So cryptorchidism will increase the risk of testicular cancer, and we know that 10% of patients with testicular cancer, they have a history of cryptorchidism. So cryptorchidism will increase the risk of testicular cancer up to threefold if orchidopexy was done before the age of 13, while if the orchidopexy done after the age of 13 years, the risk will be sixfold.
Okay. Can testicular cancer present as bilateral masses?
Yes, this is quite uncommon, but it may happen in about 1 to 2% of the people.
Okay. And what is a predominant type of testicular tumor?
According to the WHO classification of testicular cancer, germ cell tumor are the main type, which represent about 95%. The other 5% could be a 6-cord stromal tumor, like the Leydig and Sertoli cell tumor, or other rare tumor like lymphoma, metastatic lesion, and adenomatoid tumor of the epididymis.
Okay. So you examine the patient and you can feel a slight hardness on the left testis. How are you going to proceed? Nothing else in the examination, nothing else in the history. So how are you going to proceed from here?
So since the history and examination suggests of testicular cancer in this patient, then I will order an urgent blood test looking for the alpha-fetoprotein, beta-SCG, LDH, and I will do a baseline kidney function and full blood count. After that, I will take the patient myself to the radiology department and to get an ultrasound. So if the ultrasound is also suggestive of my physical examination of testicular cancer, we know that the ultrasound is quite sensitive with around 100% sensitivity and specificity. Therefore, I will expedite the patient treatment as much as possible. I want to complete my staging by doing a CT chest, abdomen, and pelvis. And then I will book the patient for an urgent right-sided radical inguinal orchiectomy.
All right. And can we differentiate the type of testicular tumors in ultrasound scan?
The ultrasound, usually most of the germ cell tumor, it is difficult to differentiate from the ultrasound alone. Sometimes specific type of testicular cancer, like sometimes the teratoma, I think occasionally may be a little bit different from them.
Okay, so this is one of the commonest questions. It can be asked in two types. Sometimes you will be given a ultrasound scan picture, and the appearance of the ultrasound scan will be homogeneous, in which case it is more suggestive only, not evident, but more suggestive of seminoma. And if it is heterogeneous in appearance, then it is more suggestive of non-seminoma. Right. You can answer it. That's one way of answering it, or you can say that it's very difficult to say what type of tumor it is in the ultrasound scan. And will you do any imaging for the brain, like any CT scan or MRI brain?
Not routinely. According to the EAU guideline 2021, brain CT is indicated if the patient having symptoms like headache or a neurological symptom, or if the patient is having widespread metastatic disease, especially with multiple lung mets and or a very high level of human chorionic gonadotrophin, because we know that most of the brain mets happen with the choriocarcinoma mainly.
Okay. And will you do FDG PET as part of the initial staging?
PET scan mainly is preserved for patient with testicular seminoma who received chemotherapy and they still have a residual mass more than 3 centimeters after 8 weeks following the chemotherapy.
Okay. So you have done the serum tumor markers. What is the importance of serum tumor markers in testicular tumor?
It's important for primary diagnosis, and then it's important for follow-up of the treatment and for prognosis and the staging as well. The main tumor marker that we are using is alpha-fetoprotein, beta-SCH, and LDH. So in seminoma, we expect only 30% of seminoma to show a positive tumor marker, while in non-seminoma, 90% of the patient, they will have at least one elevated tumor marker. So this is the importance in detection of the cancer.
All right. And what about the further treatment and follow-up? Is it important?
Yes, because usually when there is elevated tumor marker, we need to repeat the tumor marker 1 week after the surgery. And the tumor marker also involved in the staging. So in addition to the TNM classic staging, we have S stage in testicular cancer. And then according to the level of the tumor marker, we can divide the patient into S1, S2, or S3. And this will affect his prognostic group and treatment as well. Okay. And
regarding the timing of tumor marker and for staging of S, what timing of tumor marker will you do? Is it before the surgery or after the surgery tumor marker level you do for S staging?
For S staging, mainly the reliable one is the one after the surgery.
Yeah, so the post-operative. Well done. What is the half-life of AFP?
So alpha-fetoprotein half-life is 3 to 5 days. For beta-HCG, it is 24 to 36 hours.
Okay. Is there any condition where the AFP can raise without a testicular tumor?
Yes. alpha-fetoprotein expected to be high during the first year of life. And also it's an increase in certain malignancy like the liver, colon, and lung cancer. And also if we have a chronic liver disease like liver cirrhosis, all this may lead to an increase in the alpha-fetoprotein.
Well done. So can you tell me once more the plan for this patient? So the ultrasound scan shows a mass on the left testis. The CT scan is normal, no distant metastasis. His right testis seemed to be normal in ultrasound scan, normal size and nothing abnormal in the texture. And he hasn't, he's not married. So how are you going to counsel him regarding the further treatment?
Okay, so I need to know also from the ultrasound the size of the testicular mass, and I want also to know about the staging from the CT. Counseling of the patient, sorry, I may get it wrong the first time. I said right radical inguinal orchiectomy, but it should be a left radical inguinal orchiectomy. Sorry for that. So for this patient, I will counsel him that he need an urgent left radical inguinal orchiectomy. I will explain that. I will counsel the patient about the benefit from the treatment, the risk, and unfortunately in this case we don't have alternative. I will give the patient the Bausch leaflet for the procedure. I'll explain that the procedure will be done through inguinal incision. We'll remove the testis and the spermatic cord as high as we can reach. It is done as a day case. The patient expected to have some complication after the procedure, including the usual complication of anesthesia, bleeding, infection, and pain. I will counsel, importantly for this patient, a young patient who is having no children, I will counsel the patient about semen cryopreservation, and also I will counsel him about whether he is interested in having testicular prosthesis or not, and also I will counsel him whether we need to have a biopsy from the contralateral testis or not. I will make sure that all the information is synced down with the patient, and I will support my counseling with the Bausch leaflet.
All right. So why we are doing inguinal orchiectomy? Why not scrotal orchiectomy?
Because if we do anisocrotal violation, then the direction of lymph node metastasis will be shifted from the usual site, which is the para-aortic, into mainly the inguinal and iliac lymph node in addition to the para-aortic.
Okay, so what is the clinical implication of that?
Clinical implication of that if the patient is going to have a retroperitoneal lymph node dissection or radiotherapy, then the field of treatment will be quite wide, and this will cause further sequelae and complication.
Okay, so there is increased local recurrence, isn't it, when you do the scrotal orchiectomy? And well done. Regarding the testicular processes, how are you going to counsel him? Will you do it at the same time of the surgery, or will you do it as a staged procedure?
So I will inform the patient that we can insert the prosthesis at the same time of the radical orchiectomy, and we have evidence from Robinson et al. 2014 BJU that there is no increased risk of complications, especially infectious complication, after simultaneous insertion of the prosthesis with the radical orchiectomy. I will counsel the patient that the prosthesis may cause some complication, 3 to 8%. It may cause extrusion through the skin, and about 3 to 5% it may be associated with scrotal contraction and migration of the prosthesis, and in about 1 to 3% it may cause infection, pain, or hematoma formation.
Well done. And how are you going to arrange for semen cryopreservation?
So for semen cryopreservation, the patient need to have a screening for HIV 1 and 2 and hepatitis B and C. And after that, I will refer the patient to the fertility clinic who are offering this service. He needs to do 3 semen samples with 2 to 3 day abstinence in between them. And then the semen will be preserved in liquid nitrogen at a temperature of minus 196. Usually the initial cost of the preservation, including the blood test and the consultation and the storage for the first year, is covered by the NHS. But after that, if the patient wants to keep it for longer, then he needs to pay about 200 to 450 pounds per year. And usually it is kept for 10 years or up to the age of 55 years. I want to warn the patient that he may need to travel to a little bit far center if there is no nearby facilities. And also I want to warn the patient that there is no guarantee about the quality of the semen when the sample is stored in a few years time. So you need to be aware of that.
Okay, well done. Regarding the timing of cryopreservation, has it to be mandatory before the osteectomy?
It is preferable to be before the osteectomy. We know that patients with testicular cancer, about 50% of them, they have impaired spermatogenesis already, and they have abnormal seminal parameters. And we have evidence from the French Cancer Network study that orchiectomy will reduce the seminal parameters significantly in the patient. So I would prefer to do the sperm cryopreservation before the orchiectomy if it is possible. If not, then we can do it after the orchiectomy, but it's preferable to be done before the chemotherapy. And even if the patient, due to some reason, it was not done, it still can be done even within 1 week of starting the chemotherapy.
Well done. What if the semen sample shows azoospermia or severe oligospermia, like less than 1 million per ml?
So for this patient, I will counsel him about the need to have an onco-TC at the same time of the radical orchiectomy. Mm-hmm. So on the onco-TC, we examine the testis under microscope, and we try to retrieve as much as possible of viable sperm. And the success rate or the sperm retrieval rate in onco-TC is around 30%.
Okay, well done. And regarding you said that you will counsel him or might consider counseling him for a contralateral biopsy. Will you do it in all patients, or are there any specific indications for the contralateral biopsy of the testes?
According to the EUA guideline 2021, the main risk factor in male less than 40 years of age, and the risk factors include if the contralateral testicular volume is less than 12 ml, or if the patient known to have a cryptorchidism, or there is a poor spermatogenesis in the other testes. So these are the indication, because these factors will increase the risk of contralateral germ cell, this will increase the risk of testicular testicular CIS or germ cell intraepithelial neoplasia. The usual incidence is about 5 to 10% in the contralateral testis, but if the patient having this additional risk factor, the risk can increase up to 34%.
Okay, and how are you going to do the biopsy?
So the biopsy will be done through secrotal incision. I will do the secrotal incision, deliver the testis, and then I will do a small 5 millimeter incision in the upper and in the lower pool. And then with a sharp scissor, I will take some seminiferous tubule, close the defect, and send the sample in a bound solution.
Well done. What if for a patient who had a inguinal orchidectomy on one side, and if the other testis biopsy shows GC-NIS, what are we going to do with that information?
So for this patient, I'll inform him that in the presence of germ cell intraepithelial neoplasia, the risk of progression into invasive testicular cancer is about 50% in 5 years, 70% in 7 years. Therefore, I would recommend a treatment rather than surveillance for this patient, unless it is the patient wish or the patient didn't complete his family. So I'll ask him to do that as soon as possible with a close observation. But if the patient completed his family, then I will consider treatment mainly in the form of radiotherapy, 16 to 20 gray. Will be delivered to the area, which reduce the risk of testicular cancer more than 90% significantly. The other option is to have orchiectomy for the patient, and the other less effective option is chemotherapy. However, in chemotherapy, 2/3 of the patient only, the risk will be reduced, and 1/3 of the patient, they still have the TIN.
Well done. So you are sitting in the MDT, you are waiting for the pathologist to tell you the report. What is the current classification of testicular cancer? Sorry, what is the current histological classification of the testicular cancer?
So testicular cancer mainly divided into testicular seminoma, or seminoma, which mainly include the classic seminoma and the spermatocytic seminoma, or the non-seminomatous germ cell tumor, which include the yolk sac tumor, embryonal carcinoma, teratoma, and choriocarcinoma. The other non-germ cell cancer include the six-chord stromal tumor, which is Leydig cell tumor, Sertoli cell tumor, granulosa cell tumor, or mixed type, and then the rare or unusual type of testicular cancer.
All right. I'll slightly change that answer because according to the updated 2016 WHO classification, it is GCNIS and derived from GCNIS, not derived from GCNIS, sex-codon stromal tumors, and the miscellaneous tumors.
Okay.
So the other one is acceptable, still acceptable, but that was the old classification. So better to say that whether that those are the keywords that we are looking for. One is the GCNIS and derived from GCNIS, and not derived from GCNIS, and the others.
Okay. Thank you.
Regarding the TNM classification, can you tell me the nodal classification, clinical or the imaging-based nodal classification of testicular cancer?
So N0, no lymph node enlargement. N1 is lymph node mass or multiple lymph node, none of them larger than 2 centimeter. N2 is lymph node mass or multiple lymph node, none of them, between 2 to 5 centimeter. And N3 is nodal mass or multiple lymph node more than 5 centimeter in diameter.
All right. So your pathology says that the histology of your gentleman shows a specimen of left radical orchiectomy with seminoma, classical type, and the size of the tumor is 3 centimeter. The staging is PT1. The CT scan has shown no abnormal lymph nodes in the retroperitoneum or nothing abnormal in the chest. The serum tumor markers were normal previously, and post-orchiectomy, there is no change in the serum tumor markers. What is the current staging of this patient?
So for this patient is PT1, N0, M0, S0, and according to the group staging, it is stage 1A.
Okay.
For this patient, I want just to know additional information from the histology, whether there is any retitis involvement or not, and what about the margins?
Well done. So there is no retitis involvement. The margins were negative. Okay. So why that question? What's the importance of retitis involvement?
Because we know that the risk of relapse or subclinical metastasis in the retroperitoneal lymph node, generally in patients with seminoma stage 1 is 15 to 20%. However, if there's a specific risk factor, which is mainly testicular volume more than 4 centimeter or retitestis involvement, then the risk can increase. Usually it is 16% if there is only one risk factor, and increase up to 32% if we have the two risk factors together.
What if no risk factors are involved? What is the chance of recurrence then?
It's 15 to 20%. Sorry, this is overall 15 to 20%. If there is no risk factor, the risk of recurrence will be 12%.
Okay. Because there are variations in the literature. According to the EAU, the numbers that I remember is 32, 16, and 6. So if both risk factors are present for a seminoma, then it is 32%. If only one is present, it is 16, and if both risk factors are not present, then it is 6%.
Okay.
According to the EAU, but the AUA it's slightly different. Maybe the literature they're referring is different. That might be the reason.
Yeah, I think the 6% came from the Ward and Jewett study, the Canadian study, which divide the risk of relapse according to the size of the tumor.
Exactly.
If it is 3 centimeter or less, it is 6%. If it is 3 to 6 centimeter, 16%. And then if it is more than 6 centimeter, it is 36%.
Well done. Well done. So are there any predictors for relapse for seminoma, for non-seminoma?
For non-seminal stem cell tumor, the main risk factor is the presence of lymphovascular invasion, the presence of embryonal carcinoma elements more than 50%, or if the proliferation rate is more than 70%. So this will increase the risk of relapse up to 50%, while the overall risk of relapse in non-seminoma is around 30%.
Okay, well done. And so what are the treatment options for our gentleman?
So for this patient who's having stage 1A pure seminoma of the testis, for this patient, as we explained, the risk of relapse later is quite low, around 6%. So I will see the patient post-MDT with the oncology nurse. I will explain the patient the diagnosis, his staging, and the recommendation from the MDT, which is to offer him surveillance. The other options of treatment include a single cycle of carboplatin or less commonly radiotherapy.
Okay. So what is the advantage of giving single cycle of carboplatin?
So a single cycle of carboplatin will reduce the risk of relapse significantly down to 3 to 4%. And there's a study also from the Spanish group of testicular cancer, which show that if they give 2 doses of carboplatin, this will reduce the risk even down to 1.4%. However, the EAU guideline recommend a single cycle of carboplatin.
Okay. What was the shortcoming of Spanish study?
I'm not aware of that.
Yeah, so it is the number of patients, and the follow-up was only for 34 months.
Okay.
So even though it was exciting to see that it is 1.4%, that's why it is not considered as a standard until now. It might change later. What about radiotherapy? How much the risk is reduced if an adjuvant radiotherapy is given for clinical stage 1 seminoma?
The risk reduction will be the same like the single dose of carboplatin, which is around 3 to 5%. And this is the finding from the MRC TE19 study by Oliver, and which caused a significant change in the way that we are treating stage 1 seminoma. So the common practice currently is to give a single cycle of carboplatin rather than radiotherapy, since they have the same efficacy.
All right. What is the disadvantage of putting the patient for surveillance?
we need to select the patient carefully. So the patient needs to be motivated, informed, compliant with the follow-up. And then he needs to know about the low risk of relapse later on and the need for treatment later on.
All right. And what about the imaging during follow-up? Is it really intense or so? That's one.
So for the seminoma, recommended by the European guideline for stage 1 seminoma on surveillance is usually the follow-up initially for 5 years, and then if there's any follow-up after 5 years, usually it is decided upon local guideline. So in the first 2 years, the patient needs to be seen every 6 months with physical examination and the tumor marker. There is no need for chest X-ray in stage 1 seminoma, and the abdominal CT will be done twice at 3 months and 12 months in the first year. In the second year, usually it is done at 24 months. For the third year, the patient will be seen also in the clinic with a tumor marker every 6 months. However, the CT scan will be done only once at 36 months. For year 4 and 5, the patient will be seen once yearly with a tumor marker, and the CT scan will be done at 60 months. So this is a follow-up for stage 1 seminoma.
Very good. So we can say that the imaging is more and more intense, isn't it, during the surveillance. So it is very important that we have to make sure that the patient is compliant with the imaging. Yeah. Sorry, with the follow-up. I'm taking you to a different scenario now. What if the clinical scenario is non-seminomatous germ cell tumor, clinical stage 1? What are the treatment options in such a case?
So in this case, the rate of relapse is a little bit higher. If the patient having no risk factor and he is motivated and compliant, we can offer him the active surveillance. If the patient is having a risk factor, then the option of treatment is to give a single dose of BIP, which is bleomycin, etoposide, and cisplatin. The standard treatment for this patient is to give the single dose of BIP, bleomycin, etoposide, cisplatin. If the patient is not willing, then we can consider the other option, which is either surveillance or retroperitoneal lymph node dissection.
Okay. Is there any condition or any condition where we definitely consider RP-LND or nerve-sparing RP-LND? Anything in the primary pathology?
From the start, before any chemotherapy?
Yes. So out of the given options, surveillance, chemo, and RP-LND, is there any specific indication where we prefer RP-LND if there is anything abnormal in the primary tumor?
I think if the primary tumor is showing mature teratoma, and there is a normalization or plateau of the tumor marker, then we will consider replant.
Why we prefer surgery when there is teratoma?
Because it is unusual for teratoma to have, because I'm not sure.
Yeah, because teratoma is chemo-resistant, isn't it? Okay. So that's the reason that we had to consider the option of RP-LND if the primary tumor shows teratoma, especially teratoma with somatic malignant component. Regarding the adjuvant chemotherapy, you rightly said it is one cycle of BEP. Where that evidence comes from?
Sorry. So this came from the Swanetica trial, which is a Swedish-Norwegian trial in 2011, which showed that in this trial, the patients were divided into patients with lymphovascular invasion positive or negative. The patient with lymphovascular invasion positive, all of them, they given a single dose of BIP, while the lymphovascular invasion negative, they're given the choice of either having the PIP or just surveillance, and they found that one cycle of PIP reduced the chance of relapse significantly more than 90%. So the rate of relapse was 3.4% in the lymphovascular invasion positive and 1.3% in patients with lymphovascular invasion negative.
Well done, well done. So usually the viva scenarios will stop here. If you are doing like what we're doing now, if you're really excellent in your answers and you have real good knowledge and grip on the evidence, the discussion will proceed and it will go to the realm of the metastatic and the clinical stage 2. Is it all right if I can proceed to clinical stage 2?
Yes, please.
Thank you. Great. So what is the treatment option for seminoma clinical stage 2A?
So clinical stage 2A, which means a patient is having a lymph node
mass less than 2 centimeters.
Less than 2 centimeter. For this patient, usually for seminoma less than 3 centimeter, the recommendation is surveillance most of the time, and then we repeat the imaging and tumor marker in 8 weeks.
Sorry, I'll make it clear. Sorry. So in a patient who is presenting with testicular tumor, if the CT scan shows about 4 centimeter mass in the retroperitoneum, and if the primary pathology shows seminoma, what is his adjuvant treatment option?
Okay, so for this patient with a 4 centimeter mass in the retroperitoneum, for this patient, we should give a standard chemotherapy, which is, we classify the patient. We have a risk classification according to the International International Germ Cell Cancer Collaborative Group classification of the patient into good, moderate, and poor prognosis. In seminoma, we don't have a poor prognosis, so we have a good and moderate. So the good prognosis is if there is any primary, any site for a primary, and there is no non-pulmonary metastasis, and there is any beta HCG and any LDH. So this is a good prognosis. The moderate or intermediate prognosis for seminoma is if there is non-pulmonary visceral mets, and there is any primary for testicular, any primary testicular or extratesticular, and if there is any LDH and beta HCG. For the patient with a good prognosis, usually we give 3 cycles of BIP. For the patient with intermediate prognosis, we give 4 cycles of BIP.
Okay. One difference in that one is the IGCCG risk categorization, risk stratification is mainly used for metastatic ones and also for stage 2C. For stage 2A and 2B, we give it based on the evidence, but from stage 2C, we will give it based on the prognostic group classification. So for a stage 2B, I would suggest not to bring the IGCCG risk stratification, because it can be brought in when if it is a stage 2C or above.
Okay.
So for a stage 2B, but there is no difference in the treatment, not much difference in the treatment. Only thing is that if it is a seminoma, there are additional treatment options of giving radiotherapy.
Yes, the patient is not keen to have the chemotherapy, then we give a 30 gray of radiotherapy.
Okay. What if you said that for a stage 2B, you will give BEP? What if the patient has got any contraindication for bleomycin?
So the main contraindication is mainly in patients above the age of 40, heavy smoker, previous lung disease or multiple lung metastasis. In this case, we replace, we give, so in this case, we give 4 cycle of EP only, which is etiposide and the platinum without the bleomycin. And this is mainly for the low risk group, I would say.
Well done. What is clinical stage 1S?
So 1S, it means that a patient is having a high level of tumor marker, which is less than 1.5 of LDH, and a alpha fetoprotein up to 1,000, and beta HCG up to 5,000.
Okay, so for a patient with clinical stage 1S after orchidectomy, how are you going to proceed?
So for this patient, I will repeat the tumor marker after the orchiectomy, and if they are still elevated, then I will arrange for the patient to have a 3-cycle of BIP.
Okay. I would suggest to approach it like a stepwise manner. You can review the ultrasound scan again with the radiologist to see if there is anything missing on the ultrasound examination on the contralateral testis, first step. Second step, we can wait and repeat the imaging and see if there is anything shown up in the imaging later. If the imaging is stable and the tumor markers are only slightly elevated, then monitoring is an option. But if the markers rise or if the follow-up imaging shows anything abnormal, then yeah, according to we have to treat it according to the IGCCG risk stratification. What if there is a 4 centimeter residual tumor in the retroperitoneum after treatment of seminoma?
So for this patient, usually we do the tumor marker again. We have a follow-up. Usually we do a follow-up for about 8 weeks, and we do the tumor marker again and repeat imaging again. If the mass is persistent after 8 weeks, then we need to arrange for the patient to have a PET scan. If the PET scan is showing a hot spot, and then we will go with either biopsy followed by chemotherapy or radiotherapy, or the less preferable option is to do a replint.
Okay, very good. And what is the treatment for non-seminoma residual mass after first-line chemotherapy?
So residual mass, if it is less than 1 centimeter, just for observation. If it is more than 1 centimeter, then the option is to do a replint.
Okay. Is there any indication for FDG PET in non-seminoma?
I'm not aware of any indication in non-seminoma.
Okay. What are the, for a recurrence or persistence of residual mass in the retroperitoneum after non-seminoma treatment, what's the most common histology?
So in about 50% of the cases, necrotic tissue, 35% teratoma, and about 15 to 20% viable cancer. Okay,
well done. So I think we can stop here because I have answered it really brilliant and well done. Thanks so much. It was a really brilliant discussion.
Thank you.
Very good. That has taken the discussion into the Mark 8 questions, I will say. The last few questions, as Anish pointed out, will be brought in only if trainee is good in evidence and progressing fast. Some people dwell a lot in the histology, examination, tumor markers, ultrasound or orchiectomy. That will slow down, and you don't have the time to discuss the higher level retroperitoneal residual mass tumors in the exam. That will make the mark maybe around 7. But if you're able to be quite swift without wasting any time and able to produce the points in a very quick manner, you have enough time to discuss the retroperitoneal mass, recurrence, metastatic tumors. That will really give you the full Mark 8. I will say penile cancers, testicular cancers, you can see the light in the end of the tunnel, which means the portions can be completed. In one day, you can complete penile cancer and testicular cancer comfortably, fully, with whether it's Campbell, AUA, EAU, everything. Prostate cancer, of course, is quite big and it may take like 3-4 days to complete. I hope this video will give a comprehensive knowledge of at least what to cover, and also including the theoretical aspects. Hope it was very useful.
Thank you. Thank you very much.
Very good. Have a good rest of the day. It's the last working day, Friday, and we will continue this in the weekend also.
Yeah.
Bye.
Thank you very much. Really appreciate it. Thank you.
Bye.
Thank you.
Have a nice weekend.
Bye.
Bye.